Good morning, everyone. It looks like we are right on the button to get started. So thank you for joining us this morning for our panel discussion. I'm Kristen Fluitt, Senior Quality Manager at the Ohio Chapter American Academy of Pediatrics. Thank you for joining us today for this very timely and important panel discussion, Preserving the Medical Home During COVID, COVID Vaccine Administration, Making the Most of Your Visits, and Maximizing Opportunities. I want to briefly review our agenda and a few housekeeping notes. Today, Dr. Frank will be speaking to us more about vaccinating children against COVID-19, should we or shouldn't we, and vaccine best practices in the medical home. In addition, Dr. Peltier will be giving us a pediatric COVID-19 update. We're going to have a brainstorm session where we hear from you on ways that Ohio AAP can help and things that are going on in your practices currently. Unfortunately, Dr. Edgy was not able to join us today, but we do have an amazing pre-recorded presentation from her regarding vaccine hesitancy, and then we'll wrap up with a final question and answer session. I also wanted to just review a couple of housekeeping items. The intention of the chat box is for you to network, ask questions, and share whatever productive thoughts are on your mind. The Ohio AAP team looks forward to joining with you in a thoughtful and productive chat conversation today. Be sure to select everyone when you enter a chat comment. A link to claim CME or MOC credit for today's session will be posted in the chat box. CME certificates will be emailed to the address used in CME evaluations, and MOC Part 2 credit will be entered for those who complete the knowledge questions. All credits will be provided by or on November 12th. A link to the slides and recordings will be posted in the chat box and will be available after the meeting. When not speaking, please be sure to keep yourself on mute to minimize background noise. I want to briefly review our overarching objectives for today, explain the reasons for needing a COVID vaccine for children, implement vaccine best practices in the medical home, and gain knowledge of ways to address vaccine hesitancy. And finally, I want to introduce our panelists. We are very grateful for all the work they do every day, and particularly for this presentation today. First, Dr. Robert Frank is the director of the Gamble Center for Clinical Research at Cincinnati Children's Medical Center. The center houses one of just 9 National Institutes of Health funded vaccine and treatment evaluation units in the country, where he and his colleagues assess new vaccines and agents designed to prevent infections. The center is one of the COVID vaccine clinical trial sites. Dr. Frank was inspired to pursue vaccine research for pediatric patients because infections are still the leading cause of death among children worldwide. He believes that finding methods to reduce infections among children will greatly enhance children's lives and help them grow into healthy and happy adults. Dr. Frank is an acknowledged authority in infectious disease and has authored more than 125 articles and book chapters. Dr. Chris Peltier is a general pediatrician at Pediatric Associates of Mount Carmel, a 3-office, 9-physician independent practice in Cincinnati. He is also an associate professor of clinical practice and serves as the director of the community section in the Division of General and Community Pediatrics at Cincinnati Children's Hospital Medical Center. Dr. Peltier currently is the president-elect of the Ohio Chapter AAP and serves on the National AAP Council on Community Pediatrics Executive Committee. His interests include the treatment of mental health issues in children and adolescents, advocacy, practice management, community-based education of medical students and residents, and faculty development of clinical preceptors. He lives in Cincinnati with his wife and 2 children and is a diehard Cincinnati Bearcats fan. We'll try not to hold that against him today. And so now I'd like to turn it over to Dr. Robert Frank.
Thank you very much. So you can go to the next slide, please. So these are just my disclosures that I have done clinical trials for a number of different vaccine manufacturers. Next slide. And these are just 3 things that I'd like to try to get over today. And then Dr. Peltier will also be talking about the things that you probably are more interested in about how to get vaccine, how to store vaccine, how to distribute vaccine, and administer vaccine. Next. So this is like feel how a lot of us have felt over the last 18 months or 20 months, and hopefully that we're starting to get out of it. And I think the vaccines are the way that are really going to help us get out of things. Next slide. So what I wanted to start off a bit in the first place is about definitions, because I think one of the problems that's happened is that the vaccine has been held to such a high standard that people really aren't understanding or what a vaccine can do or we're looking for it to do. And also it's then provided avenues for people to kind of poke at the vaccine of saying, see, it doesn't really work. So first thing is as far as an infection. So an infection is the ability to detect an organism in your body. So if I do the PCR test and I find evidence of COVID-19, you're infected with the virus. But the disease means that you have infection with symptoms. So not only is your PCR positive, but you're having a cough or runny nose or fever or whatever. And that and one of the things with COVID-19 is that the spectrum of illness is huge. It goes from a mild cold all the way to death. So that's where people say, well, they're still getting infected. Yes, they may getting infected, but how sick are they getting? And that with that, what really, as far as healthcare providers are wanting to do to prevent moderate to severe disease. And what that means is prevent hospitalization or worse. I wish I had a vaccine that would prevent the common cold. That'd be great. It would probably put many of us pediatricians out of business, but that we're not quite there yet to totally prevent the common cold. But what this vaccine has done has had tremendous ability to decrease the hospitalizations or death. And so when people are talking about, well, people have gotten a vaccine, they've still gotten infected. Yeah, but look at how sick they're getting or what their symptoms are. It's not 100%, but it's been pretty close to 100% protective against hospitalization and death. Next slide. And so first of all, what I'd like to do is go through some of the epidemiology and then talk about the clinical trials. And then, like I say, talk to set up why we really need to do the vaccination for the kids. And so this is just from the Academy of Pediatrics. They have a weekly update on the number of cases and the number of hospitalizations, the number of deaths from the virus. And as of last week, there was over 6 million children now that have been infected. To give you an idea, just put that in perspective, there's about 75 million children in the United States under 18 years of age, so that we're now at about 7% or so of the kids that have been infected. And that over the last couple weeks that we have continued to have a number of cases. I'll show you another slide, but that the children actually there are more children being infected percentage-wise than you would expect by their representation of population. So basically saying now kids are overrepresented in the number of new infections of COVID every week. Next slide. So this is a slide looking at the incidence of COVID by age. And so over on the y-axis is the incidence of cases per 100,000, and then across the bottom is the cases by week. And that so it's a bit of a busy slide, but it's broken down by age groups. But one of the things I think is important, if you look back at the April 2020 data, is that the highest incidence was in people 75 and above. But now the lowest incidence is those 75 and above. And the highest incidence is those in 29 and below. There's a couple things, another points here is that one, as far as you look around in the middle of the slide, that's where that peak was, is Thanksgiving of last year. And so it's one of the reasons I'm excited about having a vaccine available for kids now, is to be able to vaccinate a lot of them, hopefully before Thanksgiving. To be able to get the maximum benefit of a vaccine, it's about 10 days after the second dose. But from limited data, we do know that even one dose will provide somewhere close to 70% protection about 10 to 14 days after the first dose. So while the first dose is not maximal protection, it still does give a good amount of protection. And hopefully we can blunt what we saw last year with that huge uptick in cases. The other thing is that looking back in August, is that was associated, that uptick in cases associated with kids going back to school, being close to each other, and also Delta coming through at the same time. And luckily, it looks like Delta has passed, but it's just a matter of time. We find another variant that will come and infect people that are still susceptible. Next slide. So this is just looking at kids alone and the number of cases. And so it represents the similar kind of thing as I showed you, the incidence of adults and children, but here it's just kids. And as you can see is that going back into school in August, so to the far right part of the slide, that we peaked out in the mid part of September at about 250,000 cases in 1 week, which is the highest number of cases that was ever recorded for children. To me, this just represents kids going back to school and having a number of children that are susceptible to the virus, and in unequal kind of representation of using masks and other sort of methods to decrease the risk of transmission. Next slide. And so this is just another way to kind of look at it as far as the number of cases in kids, and that it's just showing it's an upward tick over time, and that hopefully we will start to see that it's going back down for the last couple of weeks, that we will see that continue to go down. But like I said before, I think that's just a matter of time until another variant would come through and infect people that are susceptible. Next slide. So this slide is just looking at the number of cases per region to see, is there equivalent number of cases per region in the United States? And unfortunately, what we're seeing is that the number of cases in the South far outweighs the incidence in any other region. All the regions did show that peak in around November and then again in August, but the South had by far the highest numbers, and that correlates directly with the low rate of vaccination in those states. Unfortunately, while we've had about 70% of eligible people in the United States to have received at least one dose of COVID, that is not 70% of every state. There's some states that are bordering on 80 to 90%, and other states, unfortunately, are down around 30%. And the preponderance of the low vaccination rate states, unfortunately, are in the South. Next slide. And this slide's then looking at the hospitalizations associated with COVID-19. And again, it's showing it's at hospitalizations per 100,000 over time. And then the different colors are the different age groups. And that what this slide is showing is that while the highest incidence of infection is in kids in their teens and early 20s, the highest incidence of hospitalization is in the 0 to 4-year-old group. So again, it's showing as far as sort of why we're needing to immunize even down to lower age kids. And unfortunately, we're not going to have a vaccine, I don't think, below 5 for a while. But if we can vaccinate everybody else, that would be a big help for the 0 to 4-year-olds. Next slide. So to me, this is one of the most important slides in the whole talk, is that this is the COVID-19 hospitalizations in adults in the United States by vaccination status. And I can't show you one for children because we just haven't had enough kids being exposed to or having available the vaccine yet to be able to show the effect of the vaccine. But this is looking at the rate of hospitalization in vaccinated versus unvaccinated. And the blue graph is the unvaccinated people and the green is the vaccinated. So I think it's pretty clear to show that who's getting hospitalized. And that if you look at the numbers overall, since January of this year, 97.5% of the COVID-related hospitalizations and 99% of the COVID-related deaths are in unvaccinated people. So people have been asking me a lot about boosters. Yes, boosters are important, but I kind of look at it as a analogy of baking, is that to me, the primary series is making that cake. And then the boosters are the icing on the cake. Yes, the icing is important, but you need to have that cake or the icing really doesn't do you much good. So that the first thing we really need to do is to have our efforts focused on the people that have not been vaccinated. They're eligible for vaccination because that's what we're going to need to get out of this. Next slide. So this is looking at a model for projected hospitalizations based on infection rates. So a epidemiologist modeler put this together. And so just click, it'll go put a thing. So this would be saying as if, say, 5% of the kids would be infected, that would translate, because that as I mentioned to you before, we have about 75 million kids under 18 in the United States, to about 3.5 million infections, which would translate to about 9,000 kids hospitalized or in the ICU. Actually, at this time, when we hit 3.5 million, we were more at 12,000 that were hospitalized or in critical care. Next, just click again. And so if you even got up to 25% of the kids being infected, her model predicted then almost 50,000 would be hospitalized or in the ICU. And that if I can tell you is that right now we're at about, like I say, about 7 to 8%. We've had over 20,000 hospitalized so far, where she was predicting only 19,000 at 10%. So her model continues to be conservative on the hospitalization. So if even only 25% of the kids were infected, that would translate to, by her model, almost 50,000 hospitalizations and ICU admissions in the United States. By what we're seeing in reality, I would say that's probably end up being closer to 60 to 70,000 hospitalizations and ICU admissions. So when people say that the virus is not a big deal for kids, I would say it's not as common that kids are getting severe disease, but it's not zero, not by any means. Next slide. So why do we need COVID vaccines in children? This is as of last week, and you know, unless you update your slides every day, as far as your data is out of date, unfortunately. But so as of last week, we've had 584 children have died from infection. To put that in context, in a bad year for flu, usually around 120, 130 children die from the flu. So this is far above what we would expect even from a bad flu year. We've had 24,000 children have been hospitalized so far, and 5,217 have had MIS-C. One of the other things with MIS-C is we're finding 62% of those have happened in Hispanic or Black children, whereas that population only represents about 20% of the total US population. So the MIS-C is far overrepresented in people of color. And that we've seen that also just severe disease throughout the age groups is more overrepresented in Hispanics or people of color. And like I said before, we've had now over 6.3 million children been infected. But as all the pediatricians know, the pandemic has also taken a huge toll on mental health and emotional health, social well-being, and educational experience. One of the things pediatricians are well aware of, as far as with kids getting meals, that a lot of people don't realize, is that about 3.5 million children in the United States, the only place they get a reliable meal a day is in school. And so that if they're not in school, then we have a lot of children that are not knowing that they're going to get a meal that day. The other thing too, as far as for the remote learning, these schools have done a tremendous job of trying to do the best they can as far as with the remote learning. But another thing is that over 10% of the kids in the United States don't have access to computers at home. So that these kids, and unfortunately, obviously, this is going to be in the lower socioeconomic status, that there's going to be an overrepresentation of lack of learning in the lower socioeconomic group. Next slide. And then if you go then to adolescents, is that if an adolescent gets infected, about 1/3 of the hospitalized kids that end up in the intensive care unit. So if an adolescent ends up hospitalized, it ends up being a very serious infection 1/3 of the time in the ICU, and 5% of those kids end up on a ventilator. Next slide. So this slide is just trying to give an idea as far as that, why should we, another reason, why should we vaccinate kids against COVID? And so we're looking at here is other vaccines against that routinely vaccinate. And so other viral illnesses. So in the first column is the virus. The next column is the hospitalizations per 100,000 pre-vaccination. And then the next column is the deaths. And I didn't update that. I apologize. It's, like I said, now 580. So we've had 140 more children die over the last 6 weeks. So what you can see is for COVID, the hospitalization rate is basically equivalent for any of the other viral illnesses for which we immunize, other than rotavirus, which way outstrips any of the other viral illnesses for hospitalizations. But if you look at deaths, the deaths caused by COVID is far higher than any of these other viruses for which we routinely vaccinate. So our thought is that if it's important to vaccinate with those other diseases, which we think it is, then it's a no-brainer that you also need to vaccinate against COVID. Next slide. And then so a little bit now just to switch into the specific data about the clinical trials for the 12 to 15-year-olds and the 5 to 11-year-olds. That we had about 2,260 in the 12 to 15-year-olds that were randomized 1-to-1 to vaccine to placebo. That received a 30 microgram dose, which is the same dose as the adults. And then we got a baseline blood and one a month after the second dose. And then we collected adverse events and immunogenicity. So if kids were at home or after the vaccination, they started having symptoms suggestive of COVID, then their parents were to call in and they got a swab at home and we tested it for COVID. Next slide. So this is looking at the adverse events in the COVID-19 in the 12 to 15-year-olds for the 16 to 25-year-olds. So to orient you to the slide is the vertical axis is the percentage of participants, and then along the horizontal axis, the first two columns are the 12 to 15-year-old and the 16 to 25-year-old that received vaccine. The next two columns are those in the same age groups, 12 to 15 and 16 to 25, that had placebo. And so what you can see is by far and away, the most common adverse event is local reactogenicity, is pain. And it occurred about the same amount of time, percentage of time in the first and second dose. And the first dose is on the left, first dose on the right. And yes, people are happy to, they're more than willing to, I'm more than willing to share these slides. Anybody is welcome to use them. Next slide. And then this is the systemic adverse events. So after the second dose, again, just to orient you, is the vertical axis is the percentage of participants, and then across the top is the different adverse events, and then across the bottom it's set up the same way as the last slide. The first column is the 12 to 15-year-olds that got vaccine. The next one is the 16 to 25-year-olds got vaccine, then placebos. So there's a couple points on here. So this is dose 2. What we found in adolescents, the same thing we found in adults, is that there was a slightly higher frequency of the adverse events in dose 2 compared to dose 1. However, the severity of the adverse events were still mild to moderate in the kids. So we did not see a higher incidence of severity. It was just more kids had a mild side effect in the second dose than they did with the first. But a couple things here to look at too is that the fatigue, while it was higher in the kids that got the vaccine, if you look at a quarter of the kids that reported either having headache or fatigue, so if you didn't have a placebo group, you would really overrepresent the likelihood of an adverse event from the vaccine. And that's why people say, well, why do you need a placebo? Partly is because of these subjective adverse events, to really get a good understanding of how common the events are from the vaccine and how common the events are just by being in a clinical trial. Because people know they're getting something injected in their arm. This is experimental. And so they remember things, maybe, or report things that they wouldn't even think about otherwise. So next slide. So this is looking at the immune response in the 12 to 15-year-olds versus 16 to 25-year-olds. The 16 to 25-year-olds was used as the baseline. And so the immune response then for the 12 to 15-year-olds was 1,239 versus 705 for the 16 to 25-year-olds. And so it gave a geometric mean ratio. So if you divided the geometric mean titer, so basically the average titer in the 12 to 15-year-olds, you divided that by the average titer in the 16 to 25-year-olds, you ended up 1.76. So that is actually not only non-inferior, it's superior to what the 16 to 25-year-olds had for an immune response. So this is one thing where, like I said earlier, that the only thing we can do is recommend the 30 microgram dose for the 12 to 15-year-olds because we don't have enough data for the 10 micrograms. But I think this slide would show you that even if you gave 10 micrograms, I'll bet the kids would respond just fine. But those are studies that'll be conducted later. We're still trying to get those started. We're actually worried that we won't be able to get enough people to participate because there's already vaccine available, but we're still hoping we can get those done. Next slide. And then this is looking at the efficacy. So remember, the 12 to 15-year-olds, there's only about 2,500 kids. Our goal was to look at immune response, that it was at least as immunogenic in the 12 to 15-year-olds as it was in the 16 to 25. And so we collected efficacy data, but we really weren't expecting to find enough cases to be able to be saying anything. But unfortunately, there was enough COVID in the community that even with only 2,500 kids, is that we were able to show that there were no cases in the vaccine versus 16 in the placebo. And that if you then add in a group, so the top part is that kids that had no evidence of prior COVID, the next column down, or next row down is those that had evidence of prior COVID. And still no cases in the vaccine group, and then it went up to 18 cases in the placebo. So mathematically, that comes out to 100% vaccine efficacy, but I would say it is equivalent efficacy from the adults. Next. And so this is one of the things people have been asking a lot about as far as the post-emergency use authorization reported AEs, so that for any clinical trial, we know that it's possible that you're going to see adverse events when you use the vaccine. In the general population, you see adverse events that you didn't see in the clinical trial just because they're so low incidence that you couldn't see them. So this is a report that came out of Canada, and that they find that their background incidence of myocarditis. So we know myocarditis happens, right? I mean, that can happen with any virus can cause myocarditis. And actually the likelihood of myocarditis with COVID infection is about 7 times higher than the myocarditis associated with the vaccine. So that while there is some myocarditis associated with the vaccine, 7 times higher with the viral infection from COVID. So what they found from this report from Canada, where they were using that they have a socialized medicine system, so they have everybody's vaccines in a database, and they can pull all or review all the data, and that they found that as far as for the myocarditis, 79.1% occurred within 7 days of the second vaccine administration. I'm sorry, I didn't put that in there, and that almost 80% was in male, and it was after the second dose. The for the vaccine is that the Pfizer was 37.4 per million. And so that if you look at the background rate, that would be 3.74 per 100,000. So it actually probably does not exceed the background rate, whereas the Moderna vaccine was 263 per million, or which is the same as 26 per 100,000. So that the Moderna vaccine did slightly exceed the background rate. Now, the one thing is that is an annual background rate, and this other is what's happened within a couple of weeks of the vaccination. So that's the other reason that it looks like a signal you're seeing more within a temporal relationship to the vaccine. But again, looking at the absolute number, it is a bit higher. So remember these doses down here at the, I mean, the numbers down at the bottom are per million. At the top, it was per 100,000. So yes, there does look like there's a slight increase in myocarditis, particularly with the Moderna vaccine, but it is small in the few per 100,000, and that it's not much above the background rate, and that the rate of myocarditis from the virus, from the COVID virus, exceeds that from the vaccine by at least 6 to 7 times. Next slide. And so this is just look at some data about the number of kids that have been vaccinated. And so that it's estimated that about 58% of the 12 to 17-year-olds have had an initial dose, and 48% are fully vaccinated. So there's a couple points here. One is that we still have some room to improve as far as the total number of kids vaccinated. And unfortunately, just like I showed you for the number of cases of COVID throughout the country, the vaccine uptake is not equivalent across the country. Is that in the South, that some of the states are 10% or below for the vaccine of 12 to 17-year-old, whereas some of the states in the Northeast are 80% and above. But the other thing here is that if kids did get that first vaccine, it's very likely they're going to get the second. So that's a good thing to know, is that if they decided they want to get a vaccine, that they're committed to getting the series. Next slide. And this is just showing what I was saying before as far as the difference in vaccination rate throughout the country. Next slide. So then if you move on to the pediatric trials, so those under 12 years of age, what we did first is that we had 3 age groups, the 5 to less than 12 years of age, 2 to less than 5 years of age, and 6 months to less than 24 months, or 6 months to less than 2 years of age. All participants received 2 doses, study product 21 days apart. In the first place, what we did was a dose finding study. So we redid the phase 1 and evaluated 10, 20, and 30 micrograms. And in the phase 2, there was a placebo-controlled expanded cohort. What we found in phase 1 is that 10 micrograms was sufficient for the 5 to 11-year-olds. And actually, we modified these studies and that the under 5-year-olds are actually receiving 3 micrograms. So it's going to be a little bit of a difficulty for pediatric offices of having potentially even another dose of the vaccine for under 5. And that so our outcome measure the same thing as for the adolescents, looking for safety and tolerability, immunogenicity, and efficacy. Next slide. And so this is some of the results that we've seen, and this is going to be this has been accepted for publication to New England Journal. So you're seeing it before it's actually been published. So this is your benefit for being at the Ohio AAP meeting, is that you get to see data before it's been published, and you can tell your friends, yeah, I already knew that. So that for the kids, there was 2,285 children randomized 2 to 1 to receive vaccines. So the 10 micrograms are placebo. And then what we found is that the adverse event profile was good and mirrored adolescent and adult data, and actually was less, while the adverse events we saw were the exact same ones we saw in adolescents and adults. The frequency is actually lower, which I'll show you in another slide. And then the immunogenicity of the 10 micrograms was equivalent to the 30 micrograms in 16 to 25-year-olds. And that there were 3 cases of COVID in the vaccine recipients versus 16 in the placebo, which comes out to a vaccine efficacy at 91%. So again, what I would say, a vaccine efficacy equivalent to adults, so that from the data we have from 5 years of age and above, that the COVID vaccine has had tremendous efficacy that has exceeded 90% regardless of the age in which we have the data. Next slide. So this is looking at the local adverse events. So again, the exact same thing we saw with adolescents, the exact same thing we saw with adults. So it's the vertical axis of percent of participants, and then across the top is either redness, swelling, or pain. On the left side is dose 1, on the right side is dose 2, so that you'll see that and then there's either vaccine or placebo. That by far and away, again, the most common thing was pain, and that pain was higher. Likelihood of having pain was higher in the vaccine versus the placebo. But again, you see that about 1/3 of the kids in the placebo group complained of pain because you're giving them a shot. Next slide. So this is looking at the systemic adverse events after dose 2 of the 5 to 11-year-olds. And so if you remember back a few slides, I showed you the same thing for the 12 to 15-year-olds. Is that so the adverse events we saw here compared to the 12 to 15-year-olds was the same, but the frequency is lower. So that, and then again, look at the difference as far as the fatigue. There was 39% of the 5 to 11-year-olds complained of fatigue, but 24% of placebo recipients. And then headache was almost equivalent in the vaccine recipients and placebo. Again, just showing you why it's really important to have a placebo, so that you can appropriately judge the likelihood of reactogenicity attributable to the vaccine. Next slide. So here is the geometric mean ratio for the 5 to 11-year-olds, the 16 to 25-year-olds, just to show you what I was saying before, is that if you go to look at the far right, where the geometric mean ratio is 1.04. So that basically means that the geometric mean titer, the average immune response in the 5 to 11-year-olds, was equivalent to that of the 16 to 25-year-olds. I mean, you can see it's mathematically a little bit higher, 1197 versus 1146, but we were looking at as far as at least equivalency or non-inferiority, and we're able to show that. And so that's why, if parents are saying, why are you only giving a 10 microgram dose? There's no need to give any higher, that they got a fine immune response with the 10 microgram dose. Next slide. And so just to finish, a couple things. One is about the COVID-19 untruths. So the COVID-19 vaccines do not make you infertile. One of the things is that people have said, well, how do you know? Well, I think some of the data can say, as far as in the adult studies, we specifically asked women, please do not get pregnant during this trial. This is a experimental vaccine. We really do not want you to get pregnant during the time, even though we asked women not to get pregnant. Over 350 women got pregnant during the trial, so that the COVID vaccine does not work very well as a birth control method. So that there's no evidence that it has caused anything with infertility. People are now saying, well, there's a lot of menstrual irregularities in the girls that have got the vaccine. Yeah, there's a lot of menstrual irregularities in teenagers that haven't gotten vaccines. So what people are doing is that they're looking at associations. They're not looking at causation. So they're not looking at a control group, and they're just making assertions that aren't true. The vaccines do not modify your DNA. They do not cause you to test positive on PCR tests. If you are positive on a PCR test, you've been infected with the virus. That is not from the vaccine. They do not give you COVID, and they do not make you magnetic. And unfortunately, people in Ohio understand that last reference of when people were at the state house trying to prove that spoons would stick to the side of their faces and that. So next slide, I think that was the last one. No, the future. Okay, so I would say in summary is that the COVID-19 vaccines have a good safety profile and protection against disease. We now have 3 vaccines available through the EUA. So Pfizer, Moderna, and Johnson & Johnson are available for adults. The Pfizer COVID-19 vaccine is now available for children 5 years of age and above. Moderna has submitted the data to the FDA for 12 to 18-year-olds. That was done a few months ago. I have no idea why. There's not been a decision made. I can just tell you it's been submitted. I would hopefully that'll be approved soon, and there'll be a second vaccine available for the teenagers. And that I think that the vaccine for 5 to 11-year-olds will be available in offices by mid-November. But I don't think it's going to be likely we're going to see under 5 until at least the spring or summer of 2022. My guess is it's going to be really hard pressed for extending the EUA down below 5, but we'll see. So I think that's it.
So thank you so much, Dr. Frank. We did have one question in the chat box that you might be able to speak to, and that was, could you talk just a bit about the typical timeline of anticipated adverse events with any vaccine, including COVID? And that could be helpful to practitioners when they're talking to families.
Sure. So if you're going to, with any vaccine, with anything you give somebody, there's a chance for an immediate hypersensitivity reaction, immediate anaphylaxis. We have not really seen that from COVID, but that's always a possibility. But for people that are having reactogenicity, so a response to the vaccine, typically it's been within 24 hours. And if we haven't seen a response within 48 hours, some sort of side effect within 48 hours, we just really haven't seen people have it. I think it's one of the things that's important as part. People keep saying, well, we don't know the long-term side effects of the vaccine. We don't know long-term side effects. One of the things that I had to think about that. And so really what people are talking about there is medications. So that if somebody, say, has high blood pressure, or high cholesterol, or diabetes, or something that they're needing to take a medicine every day, there's a possibility that months or years down the line that you would have a cumulative effect of the medicine, and you could get an adverse event that's showing up over time. That's not what happens with vaccines. If you don't get an adverse event with a vaccine within a few weeks, the likelihood you're going to ever have a vaccine related side effects is basically 0. It doesn't mean that you can't get an adverse event that's prolonged, but if you don't have the adverse event onset within, like you say, even 6 weeks, you're not going to see it. It's not going to happen. And so it's not something that just all of a sudden miraculously happens 6 months from now, or a year or 2 years from now. And that actually that's why the FDA made the decision to say they could give the EUA based on having at least 50% of the population that received the vaccine have a 2-month period of safety evaluations, because if you don't see a side effect after 2 months with a vaccine, you just don't see it. So that's one of the things where if people say we don't have enough information for the long-term side effects, yes, we do. We've had, like I say, close to now probably 500 million doses. I'll bet it's close to that number. Certainly hundreds of millions of doses the only side effects that we've seen that we have not seen in the clinical trial, one is the myocarditis, and the other was the decreased platelets and the clotting associated with the adenoviral vector vaccine with Johnson & Johnson and the AstraZeneca. And if you look at the incidence of that for the myocarditis, like I said, it's a few per 100,000. And then for the decreased platelets, actually about 1 per 500,000. So it's more or less the likelihood of getting hit by lightning.
Thank you. I think those are great talking points again to have in mind. So I know we have Dr. Frank who's going to give us just a bit of guidance on all best practices for vaccines in the medical home. And we appreciate that as our medical director for the Moby Ties project.
Okay, so one of the things here, I'll put out a pitch for Moby and Ties is that any of you that is a program free of charge and actually comes with CME. So that if people are interested, please let the Ohio AAP office know, specifically Laura Winland, and that we can get you set up for the people to come give training in your offices. And as Lori's writing, there's a way to get free immunization resources. And so basically, one of the things that we found is missed opportunities, is that people going, and a missed opportunity is people going in and they needed a vaccine and they leave and they didn't get the vaccine. So they had an opportunity to get it and they didn't get it. So what we ask people to do is really check every time somebody comes in, regardless of the reason, their vaccine status and do they need a vaccine. Is that we've seen it for many vaccines, particularly adolescents, is that they will come in for something unrelated to them. Maybe they hurt themselves or whatever, they're wanting updated their birth control pills, something like that. As far as you have them in the office and you have an opportunity to vaccinate them, take that opportunity. Next slide. And that the other thing, as far as using a reminder recall. Now, so a reminder is that before somebody is leaving the office, is just letting them know that their vaccination is due. And as a recall is that you'd say, oh, you had a vaccine that was due today and you didn't get it. We just want to remind you and get them to come back in. One of the things that we've noticed that is, or has been shown well now, is I'm sure not surprising anyone, is that while we used to use the cards, postcards, or telephone calls and things like that, what parents and kids like the best is a text message. They find that that's what people have found, a lot of different studies, that's what people respond to the best, is they get a text message and it reminds them, and that they can answer that then when it's convenient for them. And that one of the things is that, is mentioning on the slide there too, is that one of the many bad things that's happened with COVID is that people have missed their routine appointments. Is that as Dr. Peltier and his colleague were mentioning earlier, as far as the number of decreased visits there were initially in the pandemic, and we're still trying to catch up with that for vaccination. So trying to get people back in the clinic, getting all their vaccines. And that one of the things on the prior slide is that I didn't mention specifically, is that for a killed virus, you can give as many killed viruses in a day as the people will stand, so there's no limit as far as your immune system. And you can give live viruses, all the live viruses in the same day too. The only limitation, if you give a live virus that they're due for another live virus, you need to wait at least 28 days between those. But otherwise, for killed vaccines, you can give as many in a day, and there's no waiting period to give the next dose. Next slide. Some of the things that we're discussing here, and as Dr. Peltier is mentioning, as far as the things that they were doing in their office, I think Dr. Baldwin too is having immunization only visits, having standing orders for nurses, so that the nurses have the authority to look at the vaccination status and administer vaccines. So basically, my take-home message from that is make it easy for the families to get vaccinated. One of the things that we've tried some at Cincinnati Children's is to use a mobile van to go out into the community to be able to provide people COVID-19 vaccines. We're looking at school-based vaccines too. We would love to have all the kids have their primary home in a medical practice, but for those that unfortunately don't have that option, as far as using the school as another avenue to make it easy for kids to get vaccinated. Next slide. And then Impact CIS, this is just a way to record your vaccines, and that we found this very helpful because regardless of where people have gone for their vaccinations, you can look it up, and it decreases over immunization of the kids, and it actually then helps know what vaccines kids need that they may have missed. Next slide. And so again, it's just kind of what we've gone over previously, as far as that every opportunity to remind people about vaccines or let them know about vaccines if they haven't gotten them from a text or whatever. The other thing too is to having somebody in your practice that's the go-to person for vaccine questions. It doesn't have to be a physician. It's somebody that has enough expertise, enough gravitas, and the enthusiasm, because you really need the cheerleader to be answering the questions. You answer the questions honestly, you give full answers, and yeah, so that the nurse is a great person to be able to do that, but having somebody that the parents can ask their questions. And that to the minor illnesses is not a reason to delay vaccinations, that even a low-grade fever now has been one where you can go ahead and give the vaccine. And what we would advocate as much as possible to use combination vaccines, because that will decrease the number of shots. One of the things that had happened a few years ago that's been, my understanding, has been taken care of, is that the Medicaid was reimbursing on the number of injections, not the vaccines, and so that some people were actually splitting and not giving combined vaccinations because there would be a different rate of reimbursement. But my understanding is that's been corrected now. You're getting reimbursed by the number of antigens that somebody is receiving rather than the number of vaccines or injections. Next slide. And that these are, as we heard earlier, as far as that some of you need to think inside the box and the outside of the box kind of people. And that, so here's some of the outside of the box ideas, maybe is that, maybe it's like McDonald's, that you have your drive-through immunization clinics, you get your coffee and fries and COVID vaccine to go. And that talking about, some of these other things are easier to mention than is to institute, but as far as extended office hours, to make it easier for the families to be having a relationship with the health department, so they're having them help with the vaccinations if you guys are overloaded. And then one of the things that I've heard people do is, it almost kind of sounded like at a restaurant to me, as far as that they were given the little discs or whatever, or given their phone numbers, and so that you sit in your car, and that when it's your turn, that you get a text to come into the clinic. Next slide. And that, and so this is just some things about best practices, and just in the interest of time, I won't read through all those, but ideas about how you might be able to improve practices for office operations. Next slide. And I think that's it. So if there's any questions there, that's fine. But otherwise, I think in the interest of time is that, why don't we turn it over to Chris, and that I'll hang out, and if there are questions at the end, be happy to answer.
Yeah,
Great,
thank you.
Oh,
Thank
sorry,
you.
Kristen,
And-
go ahead.
Oh, sorry. And also, I think that's a great suggestion. Continue to chat with Dr. Frank in the chat box, and he will answer additional questions or topics. And we will hand it over now to Dr. Peltier.
Great. Before I jump into this, I wanted to, there was a question or comment in the chat box about the lack of information from school-based health centers, and parents believe that if students get vaccines or access services at school, then their medical home changes. So we actually, about 2 years ago, kind of were faced with a similar situation. One of the large school districts right in where our practice is, partnered with a a federally qualified health center to set up a school-based health clinic in their school, which was fantastic. Believe me, I am all about access, but I'm also a huge proponent of keeping services in the medical home. So I would suggest, again, communication. So setting up some meetings with that school-based health center to really find out what exactly are they doing, and reminding them that many of the patients that are in that school actually have that you are their medical home. And while it definitely, for same day ill visits, if parents can't get out of work and they need to see their child for an ill visit, great. But I think reminding the school-based health centers that you have, that you're the medical home, and then reminding families all of the services that you provide, and reminding them that well visits just aren't about vaccines, that there are obviously other things you're doing: developmental screening, growth and nutrition, vision screening, mental health screening. So I think it's really just communicating to that. I think school-based health centers are great for families that don't have access to primary care providers, but having those conversations with the family and the school-based health centers. So, all right, next slide, Kristen. So I'm going to go through, this is a presentation that some of you may have seen before. It was in the last couple of weeks. And these are actually, we want to thank the Ohio Department of Health for sharing these slides. This was really a presentation that ODH did on getting ready to order COVID vaccine for kids 5 to 11-year-olds and how to actually order it. So I will say this was done about 2 weeks ago, and some of these slides are already out of date because it was when the FDA met on October 26th, but I'll update them as we go. Next slide, please. So again, as we know, there are many, as Dr. Frank said, many studies going on right now. And so all of this is subject and will change sometimes daily, weekly. So next slide. As you know, now we know that the FDA's Vaccine and Related Biological Products Advisory Committee met on October 26th and unanimously 17-0 approved authorization for the Pfizer vaccine for kids 5 to 11. I think it was fully approved late yesterday by the FDA. So now it goes to the CDC and the Advisory Committee on Immunization Practices, which meets November 2nd and 3rd. And then hopefully by the end of the 3rd, we will have an answer and be able to get vaccine hopefully in the next week or so after that. Next slide. And I will say I have no inside information as to when. I can tell you what I think is going to happen, but I do not have any inside information on when ODH specifically will be sending out vaccine. But I will say I do believe it will be soon after it is approved. So again, this is a different product. I think many of us were assuming that when we knew that it was going to be a smaller dose. I will say I don't think I knew, and many of my colleagues knew, that it was going to be a separate formulation, right? So we just can't draw up 1/3 of the dose. So as you heard from my partner Mike Chamberlain earlier this morning, right, our practice has been giving COVID vaccine to 12 to 16-year-olds and parents for many months now. So we just thought, well, you're just going to drop 1/3 of the dose, but that's actually not the case. This is a brand new product with different dosage from the adult formulation. It is a new packaging, and it has a new NDC code, and there will also be different CPT codes that you will need to import into your EHR. And I believe those are now out and available, I think I saw. But so the current product for adults and adolescents should not be used in children, and vice versa. The pediatric product should not be used for adults or adolescents. So obviously storage and again, having a system to cut down on any vaccine errors, right? So the current adult adolescent formulation has a purple top, and the new pediatric formulation will have an orange top. And again, is about 1/3 of the dose. Next slide, Kristen. Again, purple top for adults and adolescents, orange top for kids. They are not interchangeable. Don't do that. Next slide. So some storage and handling. And just FYI, I put in the chat a few things. I'll put it again right now. There's a really nice sort of a 4 or 5 page handout from ODH that goes over a lot of this in sort of more of text form. So that's up in the chat. I will do that again when we get to the Q&A. It's hard for me to multitask while I'm talking. So the pediatric COVID-19 vaccine, if you are lucky enough to have a minus 90 degrees Celsius, or minus 60 to minus 90 degree freezer, which, let's face it, right, none of us in practice do, but this is really more for those of you that are owned by a hospital system, or maybe working with your health departments, right? So if your organization has a deep freeze, that vaccine can be stored for up to 6 months. For the majority of us that do have a vaccine refrigerator that goes from 2 degrees Celsius to 8 degrees Celsius, you can store that vaccine for up to 10 weeks. So almost 3 months, but not quite. And then similar to the adolescent adult preparation, once the vial is punctured by a needle, you have to use that vial within 6 hours. Next slide. So again, pending FDA authorization, which now we have, right? So just some things that I think Dr. Baldwin was talking about, some of the boxing differences as I'm seeing things pop up in the chat. It's going to be smaller in size and weight. Each carton will contain 10 multi-dose vials, which is 100 doses. And I think there was a question in this morning's presentation that first shipment that you order from ODH must be for 300 doses. And I will tell you, for those of you with multiple offices, you have a couple of options. So we were a little leery. We currently have been shipping the adolescent vaccines, which you can order in 100-dose aliquots to all 3 of our sites. We were a little reticent to do that. We didn't want to send 300 doses to all 3 of our sites. So we are in the process of having some discussions, and I will admit I don't have an answer yet, but our head nurse, our vaccine advocate in our office, has been having some discussions with ODH to find out how we can sort of split that initial aliquot up and keeping cold chain and transferring it from one office to another office. Each vial does contain 10 doses. And you do need to have a preservative-free normal saline diluent that is included in the ancillary kit, and you need 1.3 mLs required for dilution. Next slide, please. So ordering is already open. It opened up on October 20th, and that initial dose they originally wanted it by noon on Wednesday. I'm assuming you probably can still go in. We did our dose that morning, and then you can still go in now and order that first order of 300. There will be future opportunities to order, again, in smaller doses. And again, this is obviously, it goes without saying, only plan to order if you actually anticipate administering this to kids 5 to 11, because you cannot use it in adolescents or adults. ODH does not necessarily expect all providers to administer. So for our colleagues that are in internal medicine, for instance, and may not obviously ever touch any pediatric patients, they would not necessarily, they would be able to order the adult dose, but not this. And then of course, VOMS, which is the vaccine ordering management system through ODH, is open and up 24 hours a day, 7 days a week. Next slide, please. Again, that first dose is 300 doses. Future orders will be in lower increments of 100 doses, which is currently, for those of you that are doing adolescents and adults, that's what we can order now. Interesting, if you feel like you're a very small practice and that's going to be way too much, and you don't want to order that much, ODH will help you identify some other partners. It may be working with your local health department. It may be working with your local hospital system. It may be partnering with a FQHC in another part of town or in an adjacent town that could help you sort of share vaccine so that you are able to use 300 doses. So I would recommend that you contact ODH if that is your situation. Next slide, Kristen. Temperature monitoring devices. Again, you have to have a refrigerator with a temperature probe or sensor that contains an active temperature display that can be easily read from the outside of the unit that shows current, minimum, and maximum temperatures, with a resettable min-max functionality, and then of course an alarm for out-of-range temperatures. Again, I'm assuming most of you all have this in your offices for our vaccines already. And again, I would highly encourage you to look into the Chapters Mobi and Ties program, because all of these resources are discussed, and they will help your office have a plan to make sure that you meet these minimum standards. Next slide. Again, daily temperature monitoring. So if you are going to have vaccine, ODH will provide you with a document to document twice daily temperature checks for each of the units when your office is open for services. So for instance, my office is open 6 days a week, but not Sundays. We are not required to do that on Sundays. And our 2 satellite offices that are not open on Saturdays and Sundays, those 2 days would be exempt. Next slide. So one of the things that we get asked all the time is when, right? When will it be shipped? So of course, ODH will remind us that doses cannot be administered until recommended by the CDC. So they were originally going to ship upon approval by the FDA, which happened yesterday. So the question is, will it happen early next week? Will it happen late next week? We don't know. Our office typically places our order by Thursday, and we usually get it on Tuesday. So again, I think as Bob said, probably within the next 2 weeks, you should be expecting to get vaccine at your office. Next slide. I'm going to just kind of show these slides. This is really a step-by-step guide to placing orders. I will say, again, our vaccine champion, who is our head nurse, does all of this. However, about 2 months ago, she went on vacation for a week, and she left me a step-by-step guide on how to go into VOMS and order it. If I can do it, you all can do it. And we were able to survive when she was gone. So just kind of, this is going to walk you through some screenshots. And again, we are going to provide everybody with these slides. And also, if you go onto ODH website, they have sort of downloadable guides on how to interact with VOMS. So you're going to log in through Impact. You're going to click on Vaccine Inventory Management. Then you're going to click on VOMS 2.0. Next slide. Once you're on the VOMS screen, you can select your site. You will click Orders and Returns, click Orders and Transfers, and you will click New Order. And you'll note that it does say it may be necessary to reconcile your inventory before ordering. And again, ODH can help you with that. That's one of the things that our office, our head nurse does every day, sort of reconciling what we've given with what we still have. Next slide. You will then expand the drop-down menu to choose an order set. Next slide. And for those, obviously we're talking about COVID-19 for Pfizer. So you would select the far right over here. This is the order set that, since we're talking about for the pediatric dosing. Next slide. There's an opportunity then, you will enter total number of doses that are requested. You will then enter your high and low temperatures for your vaccine storage unit since your last order. And you can see that Moderna and Pfizer orders will need freezer and refrigerator temperatures. You'll click on Next button. Next slide. You will then be taken to this screen where you will enter the requested number of adult and adolescent formulation doses. You will then enter how many doses you would like of the pediatric formulation. And ODH has said that they are temporarily going to pause for a short period of time shipping adult adolescent formulations while they're focusing on getting the pediatric formulation. So you may expect a little bit of lag in that adult adolescent shipment. Next slide. You'll verify your shipping address, your contact information, and delivery hours, right? If your office closes at 5 p.m., you don't want that shipment of vaccine on dry ice showing up, after you are closed. And if you need to change any of that information, you would call the ODH provider call center. And I'll leave that slide up there for a minute. If you all want to take that number down, that's probably the best number to call to get in touch with somebody at ODH in ordering. Maybe if somebody could put that in the chat, maybe Kristen, if you could put that number in the chat box, that would be fantastic. Thank you. And then you would click submit your order, and congratulations, you have now ordered. Again, I went through that kind of fast, but there are many resources on ODH's website. And again, you have the call center number. Most of you have probably been doing this for 12 to 18-year-olds, so it's probably not that much different, but wanted to show you these slides. Next slide. if your site requested to suspend shipments of COVID vaccine, so let's just say, for instance, normally ODH will ship out weekly, right? So you can pause your shipment. If that first order of 300 doses you think is going to last you 3 weeks, great. You don't want to maybe have shipped, you can pause your shipments. You can then call the provider call center, or there's an email. And Kristen, again, if you wouldn't mind putting that email in the chat box, you can request to unsuspend your shipments. And we do that. We sort of have a little COVID vaccine huddle every week with our head nurse, where we're like, how many doses are we going to order for each office? We look at how many potential patients do we have coming in? Are we doing any COVID clinics? How many do we think we're going to need? How many do we have in the refrigerator? So next slide. So again, as I said, during that first week of rolling out of the pediatric 5 to 11-year-olds for Pfizer, there will be a brief period of time during which shipments of the adult adolescent doses will be halted. You are still able to place orders for COVID-19 vaccines during this time, but there will be a lag where for a week or so you will not receive any new adolescent adults vaccine. And again, this is all about planning and communication with your vaccine team, and you're looking at your schedule for the next week or two. What are you going to need for early November? Next slide. Just a comment about vaccine wastage. So a couple things. I'm going to talk a little bit about supply too. You know, and I tell families this all the time. Initially, when COVID vaccine first came out, even before it was approved for kids 12 and up, right? It was really difficult for many people to get vaccine. The demand was much greater than the supply. We have been told that this is not the case, both nationally as well as in Ohio. If a pediatric patient 5 to 11, their family or that child wants COVID vaccine, there is plenty of vaccine available. And we talked a little bit about this morning, that Ohio Department of Health, and I've actually had this conversation with Dr. Vanderhoff, the medical director of ODH. They do recognize that the current vaccine supply, demand, and administration strategies may present an increased risk of vaccine wastage, right? That once you tap the vial, especially tapping the vial, right? You've got that 10-week period that you're planning for, but at the beginning of the day, 8 o'clock in the morning, that needle goes into the vaccine vial, you have 6 hours to use it. So we know that there's going to be some times where you may not be able to use, again, in the adolescent adult, it's 6 doses. In the pediatric, it's going to be 10 doses. So you may end up wasting some doses. ODH is aware of that. Obviously, we want to be good stewards, and we don't want to willingly waste doses. As Dr. Baldwin just said, you will end up wasting doses, and we do. I think at one point, to be honest with you, we did records reconciliation, and we were probably almost at 50-50, and that is going to happen. Is it ideal? No. But again, supply far outreaches demand. So there is no concern about that. And as I said, while ODH wants you to do everything you can to plan ahead and not waste doses, you are not going to get in trouble with ODH. So that would be my it's what I tell providers all the time. Next slide, please. Just wanted to remind a couple of people, and this brings, I want to make a point, as Bob was talking about best vaccine practices. I would like to encourage all of you, as we're really trying not just COVID vaccine, but vaccine in general, and trying to increase access, that for those of you that are not enrolled in the Vaccine for Children's program, which, as you know, is vaccines for children that are on Medicaid or have no insurance at all, if they're completely self-pay. The VFC is a state-run, federally funded state-run program that provides vaccines for our highest risk children. One of the issues, there are many administrative burdens, and there is a bill in Congress called Strengthening the VFC Program for Children, which was introduced by Kim Schreier, who is the first pediatrician in Congress. And she's from the state of Washington. And it really is looking to do a couple of things. Number one, it's looking to allow us to use the multi-antigen reimbursement codes for VFC vaccines. The other thing is that it is going to push for parity with administration payment comparable, equal to Medicare. So we will get paid more for administering vaccines. There were some other things that were in the bill that didn't make it through, some incentives, but those are the two key points. The chapter worked very hard in advocating with ODH and Ohio Department of Medicaid that we were successfully initially patients 18 and up who were on Medicaid that received COVID vaccine were eligible for a $100 gift card. Once the vaccine became available for kids 12 and up and now 5 and up, the chapter successfully advocated to include that $100 gift card for all Medicaid patients who received the COVID vaccine. So this handout is available on our chapter COVID resource page. We printed it out and posted it in all of our exam rooms, and it's very simple. There's a website or a number that they can text to be able to claim that $100 gift card. And that is going to continue through at least the end of this calendar year and hopefully longer. Next slide. The other win for the chapter was in payment for COVID administration fee. As you know, those of you that give COVID in your office, there is no cost for the vaccine itself. Private insurance payment for that administration code is about $39. We were able to successfully advocate that the payment for Medicaid patients is $100. And again, that currently is scheduled to run through the end of the year, and we are working to advocate to extend that beyond the first of the year. And this really was from advocacy that the chapter did, from some feedback from our members. So thank you to our advocacy team. Next slide. And again, here's just some ODH information, the ODH website, along with our COVID resource website on the chapter. And I know Kristen's been putting in the email address as well as the customer call number if you have questions or concerns. Next slide. One other resource that we're going to put a link in the chat box, as well as posting on our COVID webpage resource page, is a video from our colleague, Dr. Arthur Lavin, who's a pediatrician in a 2-person independent practice in Cleveland. And he kind of walks through, similar to the slides that I went through. So it's another format in which he kind of goes through his process that his practice did, his trials and tribulations and problem solving, and how he overcame some of those barriers. Next slide. Before we sort of open it to questions and some open discussion, I wanted to do, this is not obviously vaccine related, but some of you may have seen that recently ODH has updated school quarantine guidelines. So I wanted to just briefly go over those a little bit. Next slide. So from Ohio Department of Health, this was based on some studies that were done in Warren County, which is in the northern part of Cincinnati. And the goal of really looking at these school quarantine guidelines was to limit the unintended consequences that quarantining students had on not allowing kids to be in school. And then, of course, the added strains placed on parents, schools, and the local health departments. So similar to how almost a year ago, ODH, after doing some studies in school districts, said that if you are wearing masks and you're social distancing and there is an in-school COVID exposure, you do not have to quarantine as long as you're asymptomatic. Well, this takes us one step further. This is sort of the next evolution in this. So first off, this only applies to in-school exposures to students and staff. So it's not during a sporting event. This is in classroom. These new guidelines incorporate wearing masks as well as testing to reduce the chance of spread of COVID-19 within a structured school setting. And based on data that was collected from these pilots, it provides a safe alternative to out-of-school quarantine. And basically, if you are fully vaccinated or consistently wearing masks in school, students can already remain in the classroom, as I mentioned. Next slide. So there's two new sort of programs. The first is the Mask to Stay. And basically what this will allow is that direct contacts in a school environment, regardless of whether you're vaccinated or you're wearing a mask. And that's the big change, right? So all of the other guidelines of if you're exposed in school, you're asymptomatic and you're masked, you don't have to be quarantined at home. So this now removes sort of the mask issue. They may remain in the classroom if all of these criteria are met. Number one, you wear a mask for 14 days after that last date of exposure in the classroom. Number two, either the child or the parent for younger kids must monitor for symptoms. And if you develop symptoms, you are now out of this algorithm. So this is only for asymptomatic patients exposed in a school classroom setting. So obviously, if you develop symptoms, you then have to isolate and get tested. And students and staff may discontinue these procedures after 7 days if number one, they remain asymptomatic, and number two, they have a negative COVID test between 5 to 7 days. So if your child does not want to, or the parent does not want that child to wear a mask for 14 days, they can at day 5 get a COVID test. If it's negative, after day 7, they can stop wearing that mask. Although we would encourage that they continue to wear a mask, but these are the new guidelines. Next slide. The second new protocol involves sports. So this is test to play. So this is if you have a direct exposure in a classroom setting and you are asymptomatic, that you, child, may continue to participate in sports and other extracurricular activities if, again, these three criteria are met. Number one, you have to wear a mask when you are on a team bus or a school van, while you're in the locker rooms, while you're sitting or standing on the sidelines. And then, of course, anytime the mask will not interfere with breathing, the activity they are participating, or creating a safety hazard. When they have their exposure, they initially have to get a COVID test. And of course, that test has to be negative. They then have to agree to getting a test between days 5 and 7 following that exposure. And if negative, they will then test out of quarantine after day 7 and can return to normal activities. Next slide. All right, Kristen, I have no idea. The chat box was blowing up. I'm gonna let you kind of go through it and see if there's anything that we need to address before we move on.
Yeah, I don't think that we've seen any questions that we need to address. We've had some great comments. I think just supporting some of the messages you gave about waste, not worrying about wasting dosages, and a lot of that contact information for ODH and links to the information you referenced are in the chat box.
Perfect. And I agree with Dr. Baldwin that parents want to bring their kids to your office to get vaccine. Maybe I'm naive. I have a feeling I'm going to have many more patients and families that want this for their kids than we did in that adolescent age group. We'll see. I've just from anecdotally the conversations I've had with families and the calls that we've been getting. So time will tell in the next couple of weeks. The other thing, so circling back, I just want to make some comments on some things that we have done, and be interested how other people are communicating to their families. So we are using lots of different ways to, once this vaccine we have it, we are utilizing our social media channels. So we have a Facebook and a Twitter page that we will be using. Of course, we'll be posting it on our web page. Through our electronic health record, we are able to do broadcast messaging via texting and emailing. So we will be sending out blasts of that. So those are all the ways that we are trying to communicate to our families. I would also, again, reach out to your local health department. So I was contacted I practice in Claremont County, and Claremont County wanted to film a PSA on COVID vaccines for age 5 to 11-year-olds. So there's three fairly large practices in Claremont County that they filmed last week. And so they are going to push that out. So contact your health department and see if they would be willing to, you could partner with them in communicating. Partner with your local children's hospital. There's lots of ways to sort of get that message out. Dr. Baldwin's going to do a Facebook Live on Thursday. So again, for those of you that are more active on social social media, please do that. I was posting on both Twitter and Facebook during Dr. Frank's presentation. I love that one slide. I think Dr. Senna called it the money slide, right? And I'm like, in case you haven't been convinced yet, here's why you need to get your kid vaccinated. So all those things that you can do, I think are really going to help get that message out. Kristen, any other questions or comments you want to highlight before we move on?
I don't think we have any more, but please keep them coming in the chat box. We will keep watching for them.
All right. You want to go ahead and move on?
I think so.
I'm going to let you go ahead and kind of moderate this.
Yeah, so we wanted to hear from you and really get some of your input on some questions. So we have some polling questions that we're going to launch. And please select, and then we'll talk about results as we go. So our first question is really, how many of you are currently administering the COVID vaccine for ages 12 and up? And I'll give everybody just a few moments to answer, and then we'll show the results of that. All right, so let's take a look. And is everyone seeing those results?
Yeah.
Just making sure.
So a great opportunity. So if one of you, again, so for those of you that put no, would you mind just putting in the chat box, what would have been some of your barriers? Why have you, why are you not doing it yet? Yep, there we go. Someone in the chat monitor just put that. I'm just curious as to, anything the chapter can do to help overcome those barriers. So staffing, right? So that's a big one. And Mike Chamberlain and I were talking about that. I agree. We're worried about burning out our staff. We really are. Most of the time when we do flu vaccine clinics, we're having staff come in extra. That's not part of their usual shift. So we're concerned about excess wastage. I agree, and I get that. I think, honestly, you just got to get over that, right? It's okay. You do the best you can, but you realize there's going to be wasting. But I would not let that hinder you. Staffing's a lot harder. So I think you have to be creative, paying, time and a half, or if you're able to do that for staff to come in. Betsy, really? That's frustrating.
Yeah, Dr. Lazaron, I have heard that from another practice in a hospital-based institution as well, that they are only providing Moderna and Johnson & Johnson.
Betsy, have you talked to the health collaborative about that? I mean, because Kate Schroeder, that's a huge issue. We should talk. We need to talk to the health collaborative about that. So, Dr. Lazaron is a family physician in Cincinnati through Christ and UC, and she commented that they are only able to get Moderna and J&J. So we'll see what we can do about that. That's extremely frustrating. So. And I would love to hear. There was definitely a couple of posts about the 15-minute thing. I'm not sure how because we haven't done a mass clinic yet. So I can tell you what we've done. Again, we definitely offer it at well visits. I offer it at sick visits. We have twice a day COVID clinics, but they are not the typical. When we do a flu clinic, we're crunching 30 to 50 people in a morning or in an evening. Obviously, we've not been able to figure out how to do that with COVID vaccine because of the 15-minute wait. So our COVID clinics are scheduled about every 15 minutes. So we spread them out a little bit. I would love to have anybody share some thoughts on how to overcome that. Dr. Baldwin had put they can wait in your waiting room. And Nicole said they do a mass clinic at their largest office after hours. So we have lots of rooms available. So that's a great idea, right? We've talked about doing one on a Sunday afternoon when our office typically isn't open. Dr. Sinha says, is it regarding the 15-minute thing, is it something that we could leave up to the parents if they want to stay for OBS? I think still now the guidelines are, I would tell you, I'd probably not be comfortable with that. I think the guidelines are they have to stay in your facility for 15 minutes. So until we hear from FDA that's no longer, I think medical legally, if something were to happen, I think you would be liable had you sent them out. I'm not sure if Bobby, you have any comments about that, but.
I would agree. I think that Well, it's probably not, there's not scientific basis for it, that as long as there's a guidance out there and you're going against that and something happens, I think that wouldn't be a good thing.
Yep. There was a comment about with every pharmacy giving the vaccine to teens, the demand in our office was not that great. So a couple of things about pharmacies. So right now, once it's approved and available for 5 to 11-year-olds, kids 7 and up will be able to get it at a pharmacy without a prescription. So you're still going to have some kids that aren't eligible for that. Although I will say, I do think we're going to see less younger kids going to pharmacies. I think parents are not going to want to take their kids to Walgreens or CVS, and you know, younger kids typically are a little bit not as thrilled with shots. Not that anybody's ever thrilled to get a shot, right? But I think that's really a key to, you know, encouraging your families to get it in your pediatric medical home, where you have medical assistants that's what they do, right? They give vaccines to young children. The kids at least are much more comfortable. They know your office a lot better. So yep, I agree with that. Just kind of looking here. I do know that some of the children's hospitals, I know Cincinnati Children's will be offering some COVID vaccines, obviously for their primary care patients, but also for other families. So that's good. The other thing I recommend, it's a little bit time consuming, but one of the things I've started having my medical assistants do is when our kids come in 12 and up, I have them do a quick impact search and check to see if they have gotten the vaccine or not. And then we can update our vaccine records. And then I know when I go into the room, if they've gotten it, great. I'm not going to bring it up because I know they've gotten both doses. So, Michelle, so Dr. Dritz had put in a comment about she agrees that we need to get over the wasting. My comment about you just need to get over that. But looking at, you know, our responsibility as the global health and is it ethically okay to give waste vaccine when many countries aren't able to do it? And I agree. Global health, you know, we could have a whole session on ethics of global health when sometimes, you know, the neighborhoods we practice in aren't very healthy either. So I agree that there is no easy answer to that.
But we are shipping a lot of vaccine to other countries now. And again, like you said, Chris, it's not a vaccine shortage issue. And unfortunately, one of the other issues is that is the cold chain. And so many parts of the world where the vaccine is the least available have the biggest problems with cold chain. So that you also need to work those problems out too. So that yes, those are areas that need to be addressed. But like you were saying, is that unfortunately, you know, as one person was mentioning earlier today in the business meeting, almost half of the kids in the United States now are eligible for Medicaid. That there's a lot of underserved children in the United States that we could reach out to too.
So this is great. The chat box is blowing up. I love this. So Dr. Cotton had mentioned that some hospital systems give vaccine at main hospital and not supplying to primary care clinics. And I know that was for a while, Dr. Warwick, who is on our board that works for TriHealth, that was an issue. So if that's your case, talk to your hospital administrators and say, hey, we need this vaccine in our clinic. I don't want to have to send my patient to another site across town to have to get this vaccine. Dr. Baldwin had mentioned that for the younger COVID clinics, they are doubling their extra PTO or giving them sort of an extra cash incentive for an evening clinic and Saturdays. Betsy, Dr. Brady recommended maybe sort of partnering with MedPeds clinics through UC Health. Dr. Dritz had asked, are there opportunities to advocate with pharmaceutical companies to modify the way they are packaging vaccines? And Michelle, I can tell you, just having been on some national calls, that I know National AAP is advocating for some of that, also looking to potentially at some point doing single dose vials so that you don't have to worry about wasting those doses. So those conversations are being had, those are being held sort of at the national level. And unfortunately, here in Ohio, ODH gets what they get, and unfortunately at the state level they don't have any opportunity to affect that. So, but that's a great question. Great. And then
all right, and I think we can launch our second question, which may
great.
very well align with our first. I'm kind of interested if anyone who is not administering it for the adolescent population will be administering it for the younger ones.
Yeah, I think we had what, a
So-
62-38
Yep,
split
split.
last time. So we'll see what this one is.
So you should be seeing it. Go ahead and select your answer. We'll give everyone just a few more seconds to get their answer in. And then
And
we'll
while that
take a
poll's
look.
populating, I'm going to let you know that the chapter is finalizing a very nice one-page handout that goes over a lot of the things that we're addressing today. And hopefully in the next week or so, we're finalizing with our communications company, Cryle, that we will be sending that out to members and posting that on our COVID web page resource. I can't say that. So we flipped the script.
Yeah.
Good.
So that's very interesting. All right, are we ready for question 3, or do we want to?
Sure. And Dr.
Okay.
Sinha's having some trouble seeing the poll, so I'm not sure.
Okay, let me get to the next polling question. Sorry, having some trouble too here now.
That's all right.
All right, here we go. Is everyone seeing that one? Which, if any of the below, are barriers to administration of COVID vaccines in your office? Check all that apply. And again, I think we've talked about some of these. This will help us get an idea of how many folks are experiencing similar barriers. We'll give it just a few more seconds to get your answers in. And if there are barriers you aren't seeing in our list, put those in the chat box.
Dr. Baldwin just posted a provocative question that for those of you that are planning to give vaccine to 5 to 11 but aren't giving to 12 and over, are you going to start giving it to older kids? So that's an interesting question. So staff limitations by far number one, right? And then lack of interest from patients, operations and safe storage concerns, which we've talked a little bit about, lack of administrative support, and then lack of interest from clinic providers and complicated process of becoming a provider are the last two. So
for that one, the lack of interest from patients, one of the things I'm curious about is that because patients aren't bringing it up to you, or is it because when you bring it up to patients, they're not interested? Kind of curious, if you don't mind to for those who selected that, put some specifics about that in the chat box. All right, and we can move on, I think, to our next one.
great.
And this one is going to get a little more at well child visits. What methods really are you currently using for reminders for those?
Oh, it does say check all that apply, but it's only a single choice, right? Look, I can only pick one. So
Oh, it may, I'm sorry, we may have set that one up with
yeah.
a single choice one. So
yeah, it is a single choice, but I'll do the one we do.
So
most.
pick the biggest one that you tend to use. All right, give it just a couple more seconds. We've got about 52% participated. So all right, and here are our results on that one.
Yeah. And Dr. Cameraman had put in the chat, there's a lot of vaccine hesitancy with parents in the inner city population, and you are teeing us up for our last panelist who's going to join us virtually. It's a pre-recorded session, but that is exactly what we are going to address is vaccine hesitancy, specifically COVID in underserved and marginalized communities. So.
All right, and then I think maybe we have time for one more poll question.
Great.
That we'll get to. And this is really a quick yes or no. We do have some resources to help. If you're interested in receiving resources and hands-on assistance to increase well care and vaccine rates, Let us know if that's something you would be interested in. And if so, please chat in your name and email address in the chat box, and then that will help us know who to follow up with.
And I will say our Safe Peds Healthy Kids Toolkit that we produced several months ago, early on in the pandemic, is phenomenal with a lot of those resources. So great.
All right, and it looks like we do have many folks who are interested in that. So yes,
Perfect.
please chat in those that information, and we will be able to follow up with you after the meeting. So thanks again for your participation and giving us all this feedback. It's very helpful. And again, please keep chatting and sharing in the chat box as we move on to the next portion of the presentation. Any final words, Dr. Peltier, before we move along?
No, I'm excited to hear my friend Dr. Edgy present. I saw this presentation when it was done live, and it's phenomenal. So I'm ready to get amongst it.
All right. So with that, we are going to move to a pre-recorded presentation from Dr. Lou Edgy on addressing vaccine hesitancy.
Give us 1 minute while we figure out our tech.
Just give us a moment. Is everyone seeing Dr. Edgy?
So Kristen, I can see the slide up and I can see, but it's not playing. And I can see her mouth is moving, but I cannot hear her.
Kristen, that may be because you're actually using your own video or your own microphone through your headset. I don't know.
From Moderna came through, I had 3 additional deaths, and then we've had none since then in the family. But then also I'm a physician, and I wanted to make sure that as a Moderna trial participant, that I could go ahead and speak to my patients and be able to have some credibility behind what the process was and what was going on with the vaccines. So I have nothing to disclose. I am the Associate Dean of Graduate Medical Education at the University of Cincinnati. So essentially, residents and fellows are folks who are training in their specialty area. And my job really is to make sure that their education is up to par, that they're getting all the resources they need for that, and that they're able to launch from a really good, healthy educational base into their careers. I am a family physician, so I have a little bit of a different perspective, but take care of kids of all ages. My youngest is 17 months old. So the objectives really are threefold. Number one, to be able to say why vaccine hesitancy is important in our pursuit of health equity. Number two, to be familiar with some causes of vaccine hesitancy. There'll be a tiny bit of overlap, but not much with Dr. Karas's. And then also to speak about 4 analogies that I found really helpful as I went through and have really talked in multiple different forums about this. So number one, talking about equality versus equity. Equality really is everyone gets exactly the same thing. So you see these crates are exactly the same size, but not everyone can see the baseball game. Here, equity is different. You provide what you need. It's outcomes based, meaning that everyone really wants to see the baseball game. Let's get everyone to that point, regardless of what it takes underneath here. And then the last one here is inclusive design, which is really trying to make sure that we actually have a system that is set up to where everyone can see the baseball game and not need any extra help. If you were to put that in the context of vaccines, first of all, equality would be same size crate. Everyone gets a vaccine and it's free for everybody. But the thing about it is equity is different. Everyone becomes vaccinated. It's outcomes oriented. And so to do that, you really have to acknowledge some uncomfortable truths that have littered the pathway to discussion about vaccines for a lot of people. We'll talk about one of those incidents. You also have to break down barriers, for example, to access. If we have vaccine drive-through clinics and somebody does not have a car, well, that free vaccine is not helpful without us addressing some of those barriers. And then everyone gets vaccinated. So again, equality would be free vaccine for all, but equity would mean let's make sure that everyone becomes vaccinated. What is health equity? It really is the assurance of the conditions for optimal health for all people. And it requires three major principles. First of all, that we have to value individuals and populations equally, that we have to recognize historic injustices, and then we have to provide resources according to the need. Again, number of crates that are needed to get the same outcome. And the whole purpose of having a focus on this is that health disparities will be eliminated when health equity is achieved. So we have to have them lockstep with each other to actually achieve equal health for everybody. So vaccine hesitancy, what we do know, and this is from the NAACP coronavirus hesitancy study, and it actually shows that Black Americans, 55% know somebody who has been diagnosed with COVID, 48% know somebody who's died or been hospitalized. Among Latinx, that's a little bit higher with 73% who know somebody and 52% who have known somebody who's hospitalized or died. As far as that goes, we also know that as far as trust goes, and Dr. Karras touched on this a little bit, trust in vaccine safety, you see how low those numbers are for Black Americans. It's 14%, a little bit higher in Latinx. And then trust in the effectiveness, also really low at 18% for Blacks and 40% for Latinx. And then trust in culturally specific testing. This was really important. Moderna actually halted their trial nationwide. They had 90 sites, of which UC Health is one of them. But they halted their trial to make sure that the percentage of folks who were in the trial were actually reflective of the percentage of Black and Latinx individuals in the community, so that we could go to those communities and say, yes, this was tested in us, and to help to eliminate one of the hesitancy concerns. Additionally, if you look at trust as far as leaders, trust in Black versus white community leaders, a Black patient is twice as likely to trust somebody who looks like them when they're relaying information. I take care of many Black patients in my community, and I get that all the time. I've had a patient who I walked into the room, and within a minute we had hugged because she was crying when I walked in. She said, I've never had a Black doctor before. This helps me not to have to explain some shared experiences that we've had. Also, trust in healthcare providers is very high. So that's something that's an important avenue to use in discussions. Also, believe it or not, Dr. Fauci has very high ratings in the Black and Latinx community, and so does the FDA. Less so the drug companies, as you see down there at 19%. One of the things that was a big concern, this is back the Tuskegee Institute trial. Basically, this was back in 1932, we had 623 Black men who were approached on behalf of the U.S. Public Health Service, faith leaders, community servants, and also the medical profession. So trusted people, and were told that they were going to get free health care and free meals, and they were going to be treated for syphilis. It was a study on syphilis. At that time, penicillin had not been discovered, but over the course of the 40 years of the trial, that was actually discovered, and it was withheld from them. Additionally, and this is one piece that was very compelling to me as a physician, a letter was sent to all the physicians in the area to not treat these individuals if they came for healthcare at their offices. But again, it wasn't until 40 years later that the Washington Star News published an article exposing the fact that these gentlemen were essentially left to fend for themselves within the trial without getting treatment. Lots of things have happened actually since then. So for example, institutional review boards are out there right now. So an IRB is something that has been put into place to make sure that there are ethical standards that are met as individuals are in trials, and there has to be training for everyone who's going to have a trial that involves humans. And we'll talk a little bit more about that, but just mentioning things like that is very helpful. The other thing is, this here is Covet. She is actually a scientist. She's one of the 2 lead scientists that discovered the Moderna vaccine. And the importance here is as we mentioned before, there's a high trust with Dr. Fauci, mentioning when I speak to patients that she works in Dr. Fauci's lab and works with him. It actually does help to increase the confidence in that space, as well as the fact that she looks like some of the patients that I speak to. As we move from vaccine hesitant to vaccine hopeful, we look at some of the data that is coming out right now out of the Kaiser Family Foundation. And this is it's an interactive thing. You can actually just Google it and it will give you up-to-date information and updates about every week or so. But basically, you can actually go ahead and click on certain buttons for different races that you want to check to see what their attitudes and responses are. So right here, this slide is on the vaccine enthusiasm. And the navy line, the very dark one that's going up, that's got 70% there at the right side of it, just shows that those are individuals who have already gotten the vaccine or will get it as soon as possible. So for Black adults, it's high. But if you go to the dark green line, that starts to uptick at 16% at the right side of the screen there. It just goes to show that we're actually getting a slowdown in the enthusiasm. And part of that between December 2020 to now has been with the boosters. And I think some sentiment that having a booster proves that the original didn't work, which is a fallacy. That is incorrect. If you go then and look at Hispanic adults with the same information, you have 66% that say, absolutely, I've already gotten it, I'll get it as soon as possible. You've got more of a straight line on those who say, definitely won't get it. And then for our Caucasian patients, we see that there's a fairly straight line there for the dark green at 15%, pretty much stayed that way, of folks who say they won't get it. This next, and so summary then for that one is that an increase in vaccine enthusiasm has slowed toward, across all racial and ethnic groups except for Caucasian patients. Right here, again, this is also Kaiser Family Foundation data, and it keeps track. And we found that there is a bit of a political divide. The lower percentages for patients who have said they already have been vaccinated, we see that the lowest numbers here are in the Republicans at 54%, and then also in patients between age 18 and 49. So the two groups between being about 57 and 58%. If you look at folks who are going to be in the definitely not category, based on what we just said, you'd also expect that in the Republican category there, 20% is pretty high, saying I will definitely not get it, and also our younger patients. So when we talk about hesitancy, we need to keep this information in mind so that we're actually meeting people where they are when they start this conversation. So this slide looks at the income of parents as it relates to their children between age 12 and 17 and the schools. So we find that the parents who actually have a higher income are more likely to be have their kids in schools where the school has given them information about COVID-19, that the schools have also encouraged them to get vaccinated, have mandated that they get vaccinated, and have asked about the kids' immune status. So higher income parents are more likely to say their child's school has provided COVID-19 information or encouraged it. Here we see that when schools encourage vaccination, the children are more likely to get vaccinated. And you see at the very top blue bar, if the school encouraged vaccination, 62% of those kids got their vaccine. If the school did not, it was down at 30%. Also, if the school provided information about COVID vaccine, 58% went ahead and got vaccinated. And if the school did not provide information, then it was down at 32%. And so again, parents whose children's school encouraged vaccination were much more likely to have their kids vaccinated. This one right here actually shows concerns of patients, of parents who have not gotten their kids vaccinated. And the concern here is basically for your Black patients and Latinx patients, they were more concerned about side effects than were Caucasian patients. They were also more likely to be concerned about fertility, and that they would be required to have the vaccine when they really didn't want it. Also, you see at the very bottom here, access was a big issue. And not so much that there weren't tons of vaccines around, but am I going to be able to be paid for time off work to go ahead and get vaccinated? Is somebody going to be able to cover my shift while I'm out to get vaccinated or get my child vaccinated? So again, Hispanic and Black patients are more likely than white parents to be concerned about access-related barriers. And then this last one from Kaiser Family Foundation is about shots and the booster. Has that caused you to be more concerned about the effectiveness of COVID-19? And Black and Hispanic adults were more concerned than white adults about the efficacy and the effectiveness of vaccines since a booster came out. I will also speak personally about access. My grandmother, who's in the middle there, is 97 years old. And so when the vaccine was approved back in December, the mRNA vaccine was approved back in December, she would have been at the top of the age group as a 97-year-old woman. But it took her till February, even though my mother, who has a doctorate, was calling every day to try and get in. Folks were taking the places within our community, driving up from Florida, driving from other places, and she did not have access. So it's very real, even though we had plenty vaccines as well. Barriers, definitely, if you don't have a physician, you're definitely going to fall through the crack if somebody's not going to be able to order. Luckily, that sort of helped out to have free vaccines at pharmacies, and that changed over time. No phone, no internet, no car, no time to get off in a workday. Innate skills for physicians, definitely, as Dr. Karras mentioned, patient stories are very compelling. There's credibility, and we'll look at that in just a second. Technical and scientific knowledge, access to understanding of research and being able to translate those in the information and research into bite-sized nuggets that patients can understand, and then experiencing advocating for individuals, which we really do every day. This slide looks at public trust, and physicians really are number 3 in the list of different folks as far as trust. So, you know, if you're not able to get the message across to a patient, definitely referring them to their physician is an important thing to consider as well. As far as the public trust, since the pandemic, we really have seen a change for the better, and confidence that medical scientists will act in the best interest of the public has gone up between 2019 and 2020. Overall, the view of medical doctors is mostly positive and increasing. And Dr. Fauci, as I see here, as I show here, he's been instrumental in also maintaining his political cool all the way through multiple different regimens of folks. So whether Democrat or Republican presidents, he's been able to be a really useful tool because he's stuck to the science, and that's always a good bet for all of us as well. This slide actually shows that there has been a partisan divide in the confidence in medical scientists and scientists in general, and that Democrats have a more trusting basis in science than, and that has grown over time. As you can see here in 2019, went up from 37 to 53 in 2020. So again, knowing this information is useful, not to be antagonistic, but to go ahead and actually understand things that may need to come up in the discussion if we're really genuinely trying to get people vaccinated. Skills that we can develop as providers and healthcare workers is to go ahead and define our goals and audience and be specific. We'll talk about that in a second. Crafting our personal stories to frame the issue, developing and sticking to your message. And again, the basis should always be science. Recognizing opportunities for advocacy, they're all over the place. And then developing relationships with partners who can be vessels to get that information across. So one thing, I love this slide. Women, this is information from the CDC. Women really are often the chief medical officers of our family. And according to CDC data, 79% of women pick the family's physician, a pediatrician or family physician. 77% make the medical visit appointments, and then 59% actually make the major health decisions in the family. So very important to make sure you're involving your mothers, as you know. I will go over 4 different analogies that I found helpful. I was counting up how many things I've done since the pandemic between podcasts and media events and things like that. I've done 97, this will be 98. And these analogies have been very helpful for me in the course of talking to patients. So changing the key in a changing lock, icing on the cake, safety deposit box, and Snapchat message. And I'll do a slide for each one of these. So for the patients who are like, yeah, no, doc, I'm good. I'm going to just wait and see. I want it to, you know, percolate a little bit more and then see how it works with everybody else. I think of this. Number one, if you think about the virus being a lock and the vaccine being a key, what you do not want to do is get concerned that your key is not going to fit in your lock anymore. So when you have a virus, like I said, being the lock, when you have a variant, that lock is starting to change shape. It's starting to change its functions, starting to change. And you want to make sure your vaccine still works against your variant. And so this is why it's really important. So far, we have been fortunate in that, yes, our Moderna vaccines and our Pfizer and so forth work very well still against, against the Delta variant. But the concern is if we keep on going into Lambda and a couple of others, that could be a problem. And you don't want to have to make brand spanking new buy vaccines to deal with these changing viruses. So it's a race against time. People have to get vaccinated. There's no time to sit on the fence while the variants continue to change. The next one, icing on the cake, this one is for the vaccine was developed way too fast, Dr. Edgy. I don't trust it. It's only been around. I want some more time. For this one, I think about the icing on the cake. And we have the SARS-CoV-2 virus, which is the COVID-19 virus, has actually been, it's a part of the family of coronaviruses. We have been studying coronaviruses for 20 years. So each one of those cakes is 10 years. So 20 years worth of study. And then when the pandemic hit, all we had to do was determine the genome of the spike protein that Dr. Karras had mentioned before so that we can make the vaccine. That took 66 days. So that was like discovering the flavor of icing and then icing the cake. So this was not a vaccine that took just 11 months to develop. This was 20 years in the making, and we just had to find the last little piece to get the information across. This third analogy of 4 is the safety deposit box. And this is for the women in particular who are concerned about vaccine effects on fertility. And I like to think of a vault. And if you think about your cell containing DNA, DNA would be a blueprint to make another Lou Edgy. And that is locked in the nucleus of the cell like a safety deposit box in that vault. When you inject mRNA, it has absolutely zero access to the safety deposit box. It will not change your DNA. It will not change the fetus's DNA. It will not affect fertility of the man or anything like that. And so that is something that has been useful as well. It really does, you're locked down. It's way too important for your DNA to be free and easy in the rest of the cell. The other thing is a Snapchat message. This one is for the vaccine may have harmful side effects on my body. And so a Snapchat message, I don't use Snapchat, but my 23-year-old daughter does. It's a message on social media that has just a really short time that it's there and then it disappears. It's not a permanent message. And so I think about the fact that mRNA lasts in the system for about 48 hours. It is very unstable. And so that's why that little lipid droplet called nanoparticle is around it to help inject it into the body and keep it stable for that. But then your side effects only should last about 48 hours if you're going to have them. So fatigue, fever, mild headache, body aches, and muscle aches, those are, and joint pain, those are really going to only last from the shot about 48 hours at the most, and then it's outside your body. Just briefly on catalytic partnerships, I'm going ahead and trying to get the message out and multiplying the effectiveness of what you're saying, speaking to community leaders, being familiar with Black and Latinx physicians in town, faith leaders, local businesses, schools, and primary care are definitely important. So again, last week, it was trial day 382. I got my booster shot. Again, I got into the Moderna trial because I wanted to have the credibility of being able to say, yes, I got my shot too. I did not hesitate. I got my shot, the very first one, September 12th. We had no idea whether mRNA technology was going to work at all at that point. And we all celebrated, all 30,000 of us in the Moderna trial, when we found out that it was effective. University of Cincinnati is one of the 90 trial sites in the country. The interesting thing and the important thing is that internally, the trial team was made of Black and Latinx clinical researchers as well. There was a base structure of a network within the Black and Latinx community. Shayna, who's on the left here, she speaks fluent Spanish, and she is the person who's my direct connect. She's the one who consented and did all that good stuff with me. And then this gentleman who was on the right, unfortunately passed on several weeks ago. He was Gary. He would take blood, and I'm still in the trial for a full 25 months to make sure my immunity stays good. And so we have a lot of boots on the ground. Then externally, what we did is we went ahead and partnered with key organizations. So the Cincinnati Medical Association is a group of Black physicians here in town, equipped them with knowledge. Dr. Fichtenbaum, who's the primary lead for the trial, came and spoke at one of our meetings, told us everything about the trial so that we were equipped with tools to talk to our patients. And for that reason, we've also been partnering with the Closing the Health Gap so we can meet patients where they are. So every couple of weeks, we have on a weekend just 1 hour where people can come back and dip back into the well of knowledge and feel more comfortable with going ahead and getting vaccinated. But we said between 18 and 49 is the age group where folks are most hesitant. We've gone ahead and tried to make sure that we're meeting people with DJs and things like that where they are, where they live. Also, just recently did something else with the school board just to make sure we're getting into the schools and speaking specifically to some of the Black and Latinx parents and kids. And then my story was picked up way back when I joined the trial, and I've sort of just had the fortune of being able to be involved with all of these different entities in some arena. This right here is also leveraging, I'll just go back one, leveraging the fact that we're physicians to go ahead and advocate for patients. So this was a letter that was written by 450 physicians here in town to try and have the school board do mandatory vaccinations for patients. We've also had Cincinnati Black Medical Association go ahead and actually write a letter to all the Black and Latinx folks in town, patients, to say we really do advocate for you getting this. And then talking about Ohio AAP resources, we have a podcast library that is there. And one of these we recorded earlier in this year with our president there. And then also there are vaccine hesitancy, other resources that are available. Dr. Karras mentioned some of them. But just some where you have a QR code, you can go ahead and get some information on your phone that you can utilize and carry around with you. So as far as objectives, one was to be able to articulate why addressing vaccine hesitancy is important, which we did. To be familiar with some causes of vaccine hesitancy, which we reviewed the Tuskegee trial and some others, and then be familiar with the 4 different analogies that I found helpful over the course of this 18 months. Key in a changing log, icing on the cake, safety deposit box, and Snapchat message. And so one thing quote-wise that I think is really important, life's most persistent and urgent question is, what are you doing for others? And this was from Martin Luther King before our pandemic. And so what more? This is true during a pandemic. And that is all I had. I wanted to say thank you.
Dr. Edgy.
All right, and that was a wonderful presentation that, again, we'll make sure you have the link for if you should want to share it with colleagues, and also the link to the resources that Dr. Edgy mentioned. So we are at 12:16, doing wonderfully on time, and we have a bit of time to do a wrap up and some final question and answers. Again, I just wanted to highlight, I know we've talked about it a lot, links have been provided in the chat box, but our COVID resource page, we keep updating this, so please have this QR code and link handy for yourself. Share it with your colleagues, share it on social media. We would love that. And then also, as we mentioned earlier, we really do want to partner with practices to provide resources and support implementations, immunization and well care best practices. So feel free to reach out to me at the email there, and I'll put that in the chat box. And then also, or chat your name and email address in, and we will follow up with you. And I will throw it back over to Dr. Frank and Dr. Peltier to answer any final questions or comments.
Yeah, I'll just say if anybody has any questions, you want to put them in the chat box. We've got a couple of minutes. I will say and share that on Thursday morning, the governor and Ohio Department of Health will be having a press conference on COVID vaccine for kids 5 to 11-year-olds. And our own Ohio AAP board member, Dr. Michelle Dritz, is going to be our primary care specialist. And Dr. Robert Frank, who you got the pleasure of listening to earlier in this presentation, will also be presenting. So very, again, Ohio AAP continues to be very involved with ODH and the governor's office and COVID vaccine efforts. I just muted myself. So, and Nicole Baldwin is still waiting for that TikTok from Dr. Bob Frank. For those of you that don't know Nicole Baldwin, you might want to Google her on Twitter, and she's quite the she is the quintessential user of TikTok in pediatric advocacy. So Dr. Frank and I are nowhere near her league. So Nicole keeps trying though. So any other last minute questions, Bob? I don't know if you have any last minute comments. Yes, there you go. This is being recorded. So there you go, Nicole. This is being recorded. So Bob, any last minute comments? Any advice or?
So I think that this is not about COVID vaccines, it's about any vaccine in general, is that as I think Dr. Edgy was explaining very eloquently, as far as that people look to us for advice, they look for us for guidance, and having a very strong and positive message is going to be the most important thing. If you are wishy-washy saying, I don't know about this COVID vaccines, people are going to walk away and not get vaccinated. So they're looking for what you think. Get yourself educated. If there are questions, let us know. I'm happy to answer any. I'm sure Chris and all the people at Ohio AAP are happy to provide you any information so you can feel very strongly about the need to vaccinate children, because that's what the parents are going to hear, or they're going to see in your actions, is that how you respond to their questions, how you promote the vaccine is going to be directly related to how the likelihood that the parents are going to receive the vaccine for their children.
I couldn't agree more. Whenever I do a media interview or I have a parent ask me, so what do you think about this vaccine for 5 to 11-year-olds? Would you recommend it? Without hesitating, without letting a second drop, I go, yes, of course. And then we talk about all the reasons why. So, all right. Well, I want to thank our presenters, Dr. Frank, obviously Dr. Edgy virtually, and of course, all of and Kristen for moderating the session. This is sort of also our wrap up for the last 2 days. Just a fantastic, lots of energy, lots of fantastic presentations. We're hoping that next year we will be able to do this virtual, or not virtually. No, we hope to be in person here at the